process. Coders have been reviewing all notes since April, so we're reading top to bottom to find potentially missing HCCs. Sometimes those diagnoses get buried in the middle of the note and they're not assessed. If you happen to mention in the middle of the note, for example, that the patient's diabetic, but you didn't assess that, with the coders reading all the notes, they're going to catch that and they will grab it for you and they'll assess it for you in your problem list. So that's only if they're not already discretely assessed. Other things that we find as well, we are going to update the problem list for you and then discretely assess, as well as specificity. So maybe they have diabetes in their problem list, but in the note you mentioned somewhere that they actually have diabetic retinopathy or something like that. We would change the unspecified diabetes code for you into that more specific one, so your problem list is pretty and ready to go for the next time you see the patient. We don't alter your note or do anything to your assessment in the note. It only affects the encounter form and the problem list for future use. Then also we have 3 indicators in Allscripts now that help identify HCC diagnoses for you. First off, there's an HCC indicator, and that's on the left of any of those diagnoses in the active problem and in the dictionary. Remember, that's the little red indicator. It's red if it hasn't been assessed yet this calendar year, and then it turns gray with a green check mark once it has been assessed. And again, that's calendar year, so January through December. So if you see the patient on December 31st and you assess an HCC, it is going to convert to red again on the 2nd of January when you see that chart again. We also have a reminder within your notes, and that's in the assessment section. And all that says is HCC problems require annual assessment. And that's in every note, regardless of if it's applicable. It's just a reminder, and it's built into that form. Then the last thing we just recently added was an HCC alert in the banner bar. Now that's patient specific. So it knows that there's an HCC in that patient's list that has not yet been assessed. And so that alert indicates for you that there's something that needs your attention. Next, what do we need from you? We just ask that you discreetly assess any diagnoses that require or affect patient care, treatment, or management at that visit, and discreetly assess any current HCCs at least once per calendar year. And then also update and maintain the active problem list to reflect what's currently accurate for that patient. So remember, they can see their diagnoses now in the portal. And so we want to make sure that it's an accurate and true reflection of their problems at that moment. That might include transitioning and or resolving problems too. Sometimes there's a lot of duplicates in there, and we want to make sure it looks clean and pretty and accurate. Does anybody have any questions for me on that? Okay, we will hand it off to you, Kim.
Okay, thank you, Tanya. Again, I think we will probably make this quick. I know it's late in the day, so we'll dive right in here. Tanya has invited me to join you today to help connect the dots really on the work that you all do on coding and documentation and the CMS payment model and how that impacts reimbursement and a total cost of care arrangement like we have with Mankato Clinic. So starting off here, first a level set as to how the mechanics of the payment model works. The underlying premise is that we're trying to balance the CMS funding and the level of care delivered. So to achieve that, CMS set up this payment model. It starts off with a baseline demographic factor, which is assigned to each Medicare Advantage participant based on the age, sex of the member, as well as the county of residence. So when we think about where we're trying to get to here, when we normalize the whole population, both Medicare Advantage and Original Medicare, we're striving to get to a risk score of 1.0 on that whole population. So when we think about the folks that are aging in, that risk score is going to be on the lower end, the 0.34, 37, 38 range. And then as we're caring for those that have been in the system a while, that are compiling chronic conditions, we want to make sure that it could be well in advance of 1.0. It could be a 5 point something. So 1.0 is just to normalize among that population. So on top of the baseline demographic factor, we're adding in disease factors based on encounter data submitted to CMS and Humana via the ICD-10 coding on claims, and that's where the work that you all are doing comes in. CMS includes these disease factors in its annual determination of the risk adjustment factor, and as Tanya mentioned, that does happen annually, so I want to make sure and pick up those chronic conditions and code them and document them at least once a year. And to the extent possible, we want to make sure that that calculation is based on each condition that is active for that member every year, and we'll talk some more about that. We want to make sure that each encounter stands alone, really, as a member, pictures that member's overall health status. And that can be, a challenge, especially if that member is seen just once a year and that encounter happens at perhaps a specialist office. So it's not always a top of mind in that setting that we're picking up all of those HCCs. But it's important to note that that evaluation happens just once a year from CMS to ensure that we're getting all of the codes submitted and that risk adjustment factor is maximized. Humana and other Medicare Advantage payers perform an annual chart review to make sure we're capturing all those codes that may have been overlooked at the time of the encounter. And to that end, we'll request charts that, based on prior claim submissions, have an open or suspect condition attached to them, and that's based on claims algorithm that we do here. So we're not going to review every single chart. We're just going to take a look at those where we think there might have been an omission. So that happens on the back end. The drawback there is that the care has been provided, and that could have happened 6, 12, or even 18 months prior to our review. So there's a built-in imbalance in that reimbursement and level of care. And so, this points out the importance of having accurate documentation and coding to that highest level of specificity on the front end during the encounter. And I think there's a lot of exciting things happening at Mankato Clinic right now. Those HCC care alerts that everyone's kind of, I think, still getting used to really go a long way to closing that gap. And I can tell you, I'm working with other providers in southern Minnesota and beyond, you're out in front of your peers, so it's exciting to be a part of what's happening here. One other item to note on the payment model, it is a prospective system, so codes that were submitted in 2015 actually determine the 2016 reimbursement. So it's really, if you think about it, an inherent flaw in the Medicare Advantage reimbursement program. Especially, Medicare serves an aging population, and their health status tends to deteriorate quickly. So I want to make sure that we get that, that timing gap closed as quickly as we can. Any questions on the overview? That's kind of a lot of information to throw out there. Okay, we'll keep going. So to kind of back up and give a big picture perspective on why your work is so important, one of the main objectives of healthcare reform is to make sure we're improving quality outcomes. So in our review of most provider coding and documentation efforts, we really do consistently see that a well-documented, well-coded patient has better health outcomes. And this is really reflected in the demographic information that CMS uses to determine reimbursement. And again, that's county by county, so it's very important. To the extent that those levels of funding are accurate, the quality of care being provided is crucial. That really determines benefits that can be offered on both the Medicare Advantage plans and benefits offered to the original Medicare population. So for us specifically, that means we're able to keep member cost share down while providing services that are most beneficial to that senior population. And that really extends to disease management programs and other community programs that are offered in specific demographic areas. So just to connect that last dot here, This goes through the actual math, how the math works. I mentioned at the outset, so we've got on the left-hand side of the screen here, the specific factors are being assigned. So a female aged 70 to 74 is assigned a base demographic factor of the 0.348. So again, when we think about a goal here of 1.0, we're pretty far away from that during the HN process. So we want to make sure to add those codes, get those codes on there as soon as possible. So that really highlights the importance of the annual wellness visit and making sure we get those folks in as soon as we can. So based on the encounter and what's happening during the visit, we're picking up CHF, COPD, morbid obesity, and then the disease interaction factor for CHF and COPD. And we'll talk a little bit more about how morbid obesity plays into the reimbursement model. It's a relatively new addition to the HCC 79 model, so it's something that we're still talking a lot to physicians and coders about, making sure that they're including that in their evaluation. We've got some good examples of how to think about that as you're going through your documentation and coding. So the demographic piece is a 0.348. We add the HCC amounts to that and come up with a total risk score of 1.686. And CMS is also doing some things behind the scenes, really beyond our control, just to make sure that we're leveling the playing field between Medicare Advantage folks and original Medicare. So they apply what they call a coding intensity factor, which takes a bit off the top for us. So final risk score in this example comes to a 1.608. Any questions on this part? Okay, we'll finish our math example here. So once the risk score is calculated, the next step is to apply that to the actual payment. So in this example, we have a planned payment rate of $781. The risk score that we brought forward from the last page was 1.608. So when we do that math, we come up with an annual reimbursement for that number of $15,072 based on what we picked up in the documentation and how that was coded. So if we take the scenario where we're not picking up the COPD or the disease interaction factor, that brings the risk score down to 1.03 and changes that annual reimbursement down to $9,600. So a pretty big difference there. And when we think about it, the level of care that was provided was worth $15,000, most likely, but was reduced to the 96 because the codes were missed and associated disease factors or disease interaction factors weren't picked up. Most likely the physician did address those conditions during the encounter, whether in plan of treatment or choice of drugs prescribed or follow-up care, but that reimbursement doesn't reflect it if it's not included in the documentation. So highlights the importance here of making sure we're coding accurately and to the highest level of specificity. Any questions on that? And again, it just goes back to making sure reimbursement ties to level of care provided, and that makes sure that we have stability in our premiums and benefit plans. So the ripple effect is also demonstrated there. So just to talk a little bit about CMS requirements, they are a federal agency, so they can have some pretty rigorous standards for documentation and coding. So the guiding principle here is that documentation is to treat each encounter as a standalone representation of the total overall health status of the member. And this can be sometimes a difficult concept to embrace. if a patient's presenting for an earache or sore throat, you're not necessarily evaluating for the ostomy or amputation. And those are commonly missed codes. And we like to mention those because they do have a pretty hefty risk adjustment factor value. They're in the 0.7, 0.9 range. So, and when you think about it, to treat a member with those conditions is probably an intense encounter. So we want to make sure that reimbursement reflects that. Other requirements specify that documentation be based on a face-to-face encounter and adhere to ICD-10 standards and guidelines. And also, we don't code from lab or x-ray, and it goes back to it has to be part of the documentation. So test results aren't part of the documentation. However, it could be part of the feedback mechanism between coder and physician, where you have the opportunity to loop back with the physician if there's an abnormal result and just double check and make sure that that condition truly wasn't evaluated during the encounter. And then, of course, we've got some contractual obligations. Humana contracts with CMS. Again, a lot of rigorous standards to be applied there. So we make sure that our contracts with providers also include, to the extent possible, we're all compliant, accurate, while being, coding to the highest level of specificity. So all those components play together.
Can I ask a question?
So,
Kim, excuse me, sorry, we have one question over here.
The lab diagnostic test you're talking about, so like I might say elevated ESR or abnormal brain MRI, you're saying those aren't codes that don't go towards payment?
So those aren't specific conditions that would map to an HCC. So the gold standard really is, especially on the Medicare side, there's an acronym that we use to make sure that we're being compliant with the documentation requirements, and it's MEAT, M-E-A-T. So the gold standard to be picked up as a code is it's being monitored, evaluated, assessed, and treated. So there might be a clue there that there's an abnormal result, but unless it's firmly documented in the assessment or plan, which again, gold standard is there's a treatment plan also involved, then that probably will not be accepted by CMS.
For payment at all? I mean, it won't be accepted as an HCC.
So that's a good question. There is a distinction between Medicare risk adjustment and your straight line ICD-10 CPT coding. So HCCs don't actually impact claim reimbursement. They're on the other side, on the Medicare revenue adjustment side.
So this is Tanya. If you were to document something in your note, your office visit, that there was an abnormal lab or there was something that you saw on the image, that is a diagnosis we would put on that claim, whether it's an HCC or not. That's okay. I think what Kim was saying is we can't grab HCCs ourselves out of a report without having your
So there are some diagnostic
assessment.
codes that are actually HCC, and the doctor has to put it in there.
Then you would put it in your note and you would have
put it
a
as
treatment
an
and a plan.
assessment.
Exactly.
Okay.
Yep.
Got
But
it.
we just can't go fishing out into the
Sure.
lab and
Got
X-ray
it.
for it.
Got
Yep.
it. Okay.
Yeah, so there is a subset of about, and it changes, probably 10,000 plus ICD-10 codes that map specifically to the HCCs that we're talking about for the Medicare risk adjustment.
Yep.
So, I think there's some 80,000 ICD-10 codes in general, but for this discussion, we're just isolating it to those chronic conditions that are on the HCC 79 list.
And I missed, what does the 79 mean? What is it?
Sorry. Sorry, Kim, we have a question about what is the 79?
So I can provide a list, actually.
Oh, I mean, that's the number?
It's-
79 things, or?
There's
Yep, it's a list of 79 conditions, yep.
categories.
Okay.
For once it's
categories.
straightforward.
Yeah.
CMS says, okay, we'll call it the HCC 79 model because there are 79 conditions.
Got it. Okay.
And they range from, there are probably a half a dozen episodic conditions, but the rest are going to be your chronic conditions, diabetes, COPD, the stuff that doesn't typically resolve. And there are codes for neoplasms, which could resolve, but for the most part, there are conditions that don't resolve, and that's why we want to make sure that when we're thinking about Medicare risk adjustment and that annual cycle, we're evaluating those members for those conditions at least once annually. So, go ahead. Good questions. Keep them coming.
If there is anything specific for psychiatry?
So, depression is a big one, and that one is frequently, if it's omitted, it's not coded to the highest level of specificity. And we do talk quite a bit about depression. So, in the ICD-9 world, the code F32.9, which was just depression, did map to an HCC. However, in ICD-10 world, if it's just noted in the impressioner plan as depression, that ICD-10 code does not map to an HCC. It has to be noted as major depression, recurrent, and hopefully with a treatment plan. So it's gotten a little bit more specific. We can't code from just the depression diagnoses. There are a few other what I would call the psych areas. So drug and alcohol, psychosis, or dependence, schizophrenia, major depressive, bipolar, and paranoia disorders. So that there are a few out there, but we want to make sure that, again, the monitor, evaluate, assess, and treat. You have to make sure that the documentation reflects that the evaluation and treatment is thorough on those conditions.
Anything for ADHD that you're thinking?
No, that one's not part of the HCC 79 model at this point. They do update it. It's not annually. It's a little bit more infrequent than that, but at this point there's not an HCC associated with that. Now, there of course there's ICD-10 codes that relate to that, but those codes do not map to an HCC.
Okay, thank you.
You're welcome. So I'll share with you the results of our last chart audit. So, Mankato Clinic overall does a very good job with documentation and coding, and I think we'll find during our next review, which we've just begun the chart request process, so we don't have those results yet, but we'll surely share them with you when they're available. Last year we took a look at 372 charts and found 17 additional modifications. So that's a pretty low rate when we compare to the rest of our provider partners in our region. So good job there, but we want to make sure that we're picking up all the reimbursement that is due. So that's worth about $50,000 in additional funding. And we do perform an 18-month look back on your cost of contract or cost of care contract. So ultimately that will be included in the final settlement for that reimbursement. So that's one of the big reasons we look at that, a retrospective review. We perform that audit to make sure that we're not leaving anything on the table there. Top categories where we found support in the documentation include renal failure and morbid obesity. And I mentioned during the presentation that morbid obesity is one of those conditions that our coders and our physician partners are all still trying to wrap their heads around, and we're doing a lot of education on how to properly document and code. So ideally it's got a couple of different components. The BMI is routinely calculated in the vitals section, which is great. A coder can't perform that calculation. It has to be within the vitals. We can pick up the BMI Z code if it's if the actual calculation is 40 or greater. However, if it's not specifically documented, and it's lower than that, there might still be a case of morbid obesity, especially if there's other existing conditions. But unless it's specified in the documentation, we can't pick out the morbid obesity unless it's in the assessment and plan. And there's a good example. What I have on the screen here is an excerpt from our coding and documentation guidelines, and this one is specifically for morbid obesity. One of the scenarios that they list talks about the vital section of the record. I'm going through example 7 here. Vital signs of the record indicates a BMI of 61.96 and final impression documents well adult exam. So, there was an opportunity there to document as morbid obesity, and, also they discussed the importance of regular exercise, encouraged to lose weight, but if it's not documented as morbid obesity as a specific diagnosis, then we can't code it as morbid obesity. We can, however, still pick up the secondary code for the high BMI calculation. So that's one where there's a bit of gray area there in terms of how the documentation impacts the way we code. And, those gray areas exist, obviously, throughout the conditions that we're evaluating. Neoplasms is another good example, and we've talked in our other sessions about, if it's an active condition, then we document, and then, what do we consider active? If it's watchful monitoring, is that an active condition? So it's those gray areas that we really want to make sure everybody's got a good understanding, and that we have good dialogue about to make sure we're all on the same page there. So we went through that fairly quickly in the interest of time and getting everyone out of the office in a timely manner as we approach 5 o'clock. We've got time for questions if there are any others. I know that Tanya and her team also have some input to say, so I don't want to take up too much time here.
Okay, thank you, Kim. We have Deb here from EHR, and she's going to talk about our problem list.
So just a couple of quick things with the HCC alerts, just kind of as reminders. Like we said, the HCC diagnoses are assigned by CMS. They can change, and they do. We just found that out recently that they have changed. There's over 42,000 diagnoses that are assigned to HCCs. So it's quite a large number.
Does automatically update that, or do you guys have to do that?
Nope.
Unless they took Hep C off, I noticed.
Oh, okay.
Yeah.
They did?
Yeah.
I just
Yeah.
quoted somebody last night.
Carboni's
with
too
Hep C.
easy. They.
Did you look at chronic Hep C though?
I went through. I searched. It's all gone. I could not
Last
find
night I
it.
quoted it though.
Really?
Somebody. Yeah.
Because I
'Cause I-
flipped it a couple months ago. I could flip it to HCC. I'll try doing it again because I always try and modify up to HCC. And
So
And
that
you might know more, but yeah, I did a chronic Hep C yesterday on a patient who also has hemochromatosis.
one thing I noticed depends on when you
Yeah,
try and
not
modify it.
HCC.
Yeah, I go
I've
back
never
and
done
search
the
it.
modify thing that you're talking
Well, you go
about.
refine ICD attributes, but I go to new because sometimes we try and refine it, won't bring up the HCC. So I search new, and I just noticed that some are disappearing, and so that I keep trying to upgrade the Hep C to. I'll keep looking because I can get an HCC. I was trying to put
Type
it on
in
there.
chronic hepatitis C because
I wonder if that's what. Because some of the wording.
sure
Okay.
that that's what I quoted last night. That's
Sweet,
what
because I'll make sure that all my guys are to
chronic.
get an HCC.
yeah.
Okay.
Not that I usually code that. But
No, that's cool. I go for the big
Yes,
guns.
yes,
I
yes,
look at
expert in
HCC. but
neurology.
Morbid obesity is one I do miss. And
oh
I
gosh,
gotta-
I'm totally missing that.
I gotta just think to put that on for
Yeah.
liver disease. So anyway, I'm sorry. Go ahead.
No,
That's
this
okay.
is perfect. This is great discussion. So we did add a new chart alert. The chart alerts are below the patient banner bar in red. That does say HCC assessment required on those patients that need those HCC assessments. It's meant to remind providers to review all your HCC flagged alerts annually, which, like we've said earlier. And again, just reminding these are for high-risk conditions and need to be also reviewed annually too. So there are some known alert issues right now. So if you come across any problems, or you're like, gosh, this just doesn't seem right, or it has an HCC alert, or it, you know, doesn't have one, let Cheryl know. You can shoot an email to Cheryl Jones, or you certainly can call EHR and we can take that message too. Depression, anxiety, and obesity right now are 3 known issues with the HCCs, and we are working on getting those
What do you
fixed.
mean? Because like mild, if you put major depression, mild, the HCC comes up.
A lot of it has to do if they've had a previous diagnosis that had an HCC and then it's been transitioned. That's where they're running into
You
some
mean,
of the
like,
problems.
Some doctor went in and transitioned it?
Yep, or if you transitioned a problem to another one, that's kind of where they're running in, or they're seeing those the most
So you might
in
see
primary
an
care. Yep.
alert, but there's
No,
no
it-
visible red HCC showing, and you
Yep.
look at like what's
Oh,
missing.
I
Why
see
is
the
this
alert
alerting
there.
me?
Yep,
Yeah.
and we're working with Galen, who's our vendor that has wrote this script and is applying these alerts to get that logic so it won't display then. So just kind of be aware of
I'm
that.
tinkering with the depression ones. I'm less sure. I'm like, yeah, it's major.
When in doubt, call coding. And then just a reminder, alerts update in the evenings. So that's when those alerts come on or those alerts go off. So every evening that runs as part of
Oh,
one
you
of our
must have
jobs.
been really looking at those alerts.
And then-
So much on
We've
that
gotten
screen.
some calls. We've gotten some calls.
Have you? Okay.
I'm
Why
just
did
trying to
it
get
go
my
away?
dictations
Oh,
done.
yeah, me too.
I
2 in the
get my
morning. Oh
codes
yeah, I
done.
forgot to check the
We
alerts.
do want you to get those done.
They're all I'm one behind the I made strides
You're
of
good.
So just a couple reminders on your problem list maintenance. Just a reminder, coding is helping to review problem lists and transition items where appropriate. So kudos to our coders for taking some of that legwork off of you guys.
You're doing that?
Yep.
Oh god, because yeah, sometimes I see notes and I'm like, holy crap, the sinus disease was in 2009. Why is it still here?
Oh, yeah. Just a couple other tips. Review problem lists for duplicates. Sometimes you're going to have the same problems and they're going to be worded a little different. Tanya uses diabetes as a great example. It might be diabetes and then it might be type 2 diabetes. So it's sorted alphabetical so that you're looking through and you're reviewing that whole problem list. You can transition those where it's appropriate if you do have a double diagnosis. If you're not sure how to do that, pick up the phone, call EHR. We'll walk you through. It takes just a few seconds to walk you through that.
You mean the process of transition?
Yes.
Oh, I didn't
Yep.
do that.
What
Perfect.
if there's like proctitis, but also a question of left-sided ulcerative colitis, and they're both HCC? Can you just have both on there?
Yeah.
Okay,
Yeah.
because that's what I've been doing.
If,
Okay,
if
I
they
can
have
see it.
both,
Yeah,
yep.
okay.
Mhm.
Actually, neurology doesn't have it in
yeah.
HCC, so.
Just
And
that
then-
they're both, I'm like,
You
oh,
get
because
them
because I
out.
just
It's
had
such
that
an
one
easy
today.
field. I mean,
right.
And then review your problem list. Review your problem list for acute items and resolve and suppress those where that's appropriate. So one of the great things that happened earlier this year is the EHR steering committee reviewed all the top diagnoses and we set resolve dates behind the scenes for acute and injuries. So they present to urgent care with a sore throat. That's going to resolve in X amount of days. So the next time they come in and it's 4 months down the road, that problem isn't hanging out there. Now that takes effect the day we set the resolve date behind the scenes. So if that problem was in prior to that, then you'll have to manually take that action. And Tanya's been working with specialty departments for that and reviewing some of those. So it's been a great feature that we can do. And then entering an error, only enter an error or problem if it's a mistake, not to remove a legitimate diagnosis. If it is legitimate, you resolve and suppress it, or you're not sure what to do, pick up the phone and call 2129 or 8780 and either EHR or coding will walk you through those steps. So, Ms. Tanya.
Yes.
Your
Well
turn.
done. Thank you. I don't have anything to add. You captured everything that I would have added, so you did great. Everything I needed to say. Do you guys have any other questions for us?
do we need to have copies of what she showed us for that?
We do have that. Yep. I believe.
Or email it
Yep.
to us?
I can send you an email with that attachment. Yep. Absolutely.
All my free time doing it.
Right when you're bored.